So we're talking about learning together. I'd like to start with the history of after action review, because the origin story for after action review sets the scene perfectly for our understanding of what AAR is and isn't. And the story began during the Vietnam War in the 1960s. Many of you watching tonight will be too young to know much about this 15-year conflict between North Vietnam and South Vietnam. The USA became heavily involved to try to prevent the spread of communism in Southeast Asia, and it proved to be very tough. And what made it so tough for the American troops was that it was not a conventional war with clear front lines or large set-piece battles. Instead, the troops faced guerrilla war conducted by the Viet Cong communist fighters in South Vietnam, who blended into the local population and launched surprise attacks and then disappeared into dense jungles and tunnel networks. In this context, the US military found that their traditional military hierarchy, where commands were issued from the top and then passed down the chain of command, these didn't work very effectively because the troops on the ground actually often knew more than the generals themselves, because the troops learned to speak the language and understand the terrain and keep track of the tactics used by the Viet Cong. So the generals realized they needed to change what they were doing, and they realized they needed to go and learn from the troops on the ground. This was completely revolutionary in the 1960s military mindset. But they adapted the post-baseball sort of match debrief and to find out what everyone had learned from each day's engagement with the enemy. And this gathering of intelligence from those directly involved and learning together from any recent action is the essence of after action review. The after action review that we use today in the NHS and in armed forces across the world. And I've included a link to an excellent paper called Learning in the Thick of It in the materials that you will be sent after today. So when I was working at University College Hospital London in 2008, my boss, Professor Aidan Halligan, witnessed the use of after action review in the military field hospital in Camp Bastion. And he recognised its potential to improve patient safety at UCLH. Because despite all the resources and the talent that we had at UCLH and still have at UCLH, quality and safety were both impacted by blame. You know, it's always easy to blame another department or another profession for what was going wrong. And it was very difficult to have conversations across the departmental and professional boundaries. And Aidan saw how useful after action review could be to enable those safe, productive conversations between departments and clinicians to drive improvements in clinical care. So we developed formal training programs, and after action review became part of the culture at UCLH. And I was one of the first people to be trained as an AAR conductor. This is the term that we use to those who facilitate after action reviews. And I wrote a paper in 2013, which describes those early years, the work we did initially on after action review at UCLH in the Journal of the Royal Society of Medicine. So that might be helpful to read. And there's also a chapter that I wrote in patient safety, emerging applications of safety science, um, which summarizes after action review. And I've put there some of the organisations that I've led after action reviews for, and done training, not to elevate myself, but to illustrate how widespread its use is and how applicable it is to so many different contexts. I mentioned the patient safety incident response framework. This is what is now embedded in the NHS. In 2022, it became part of NHS England's policy. And it's a very different approach to learning after harm, because what we used to rely on was the incident investigation process. This would take maybe 60 to 80 hours after a serious patient event, and it may take 6 months to complete the investigation. And so obviously it was only reserved for the most serious incidents. What PSERF has given us is a wider range of learning response tools. And after action review is the most widely used of those now. And what the PSERF states is that our approach to learning after harm, or when things didn't go as well as we expected, there should be a proportionate and compassionate response. By proportionate, that means that we can focus on the local issues that matter in that healthcare setting, rather than focusing on national thresholds for an investigation. So in a mental health hospital, for example, they might choose to do the after action reviews or focus after action reviews on patient restraint episodes. Whereas in an elderly care unit, they might want to focus on patient falls, so that they can learn from events about what matters to them, and to engage with patients and staff in that learning journey. And the other sort of key feature of PSERF, which is relevant to the veterinary practice as well, is actually the learning is to focus on what was happening that contributed to the error, not who. So we take the focus off the individual and look at the system in which that error happened, that event happened, because that is where we're going to be able to mitigate the risk of the future. If you just remove the person who made the error, you're not going to change the system in which that error happened. So we're really making a big switch. So what is after action review? After action review comes in the category of clinical debriefing tools. And there are many of these around in human healthcare. And they're usually designed for specific situational context. So maybe in a neonatal care, there's quite a few debriefing tools for that in neonates and in clinical simulation exercises. In contrast, the after action review tool is highly adaptable to all contexts and in healthcare and well beyond. The World Health Organization, for example, undertakes after action reviews lasting 2 days to learn from an emergency medical response to a disease outbreak. And the Ebola outbreak in Uganda at the moment, if you look at the World Health Organization website, there are a lot of after action review reports from previous outbreaks that have really helped fine tune the response to an outbreak, and has actually prevented many outbreaks escalating in the past. After action review is also a quality improvement tool. By this, I mean it can be applied to any operational context to improve performance. One of my clients led an after action review last week about a data breach, for example. So anything on the operational side. And it's a bit similar to the plan, do, study, act cycle in the QI toolbox, and it has a strong future focus. But the difference is that the after action review is a group conversation that gathers information in real time. Excuse me. Investigations, plan, do, study, act, and lessons learned activities gather evidence over time. Whereas after action review does it with everyone in the same room together. After action review is a highly inclusive practice, as those at the sharp end of care contribute fully, and all those participating have equal value. There's no hierarchy in learning. An after action review is a highly effective form of continuing professional development. It ticks all the boxes in the adult learning theory best practice guidance because it's relevant to the participants' lives, directly applicable to an individual's own work. It helps make the why of learning much clearer and encourages independent problem solving. So it's not a feedback session, a critique, or a lessons learnt report. After action review is a conversation in which people learn for themselves what happened and what might change in the future. It involves 4 questions. The first question often seems a little unusual when you first encounter it, and it can actually be quite hard to answer. But we all have expectations about everything running along in the background all of the time. You all had some expectations about what a webinar would be like, and hopefully we're meeting them. We only really notice our expectations when they're disrupted a bit in some shape or form, and we rarely get to talk about them in a group. Now, I just have to warn you, sometimes on the internet, you can see that the first question in the after action review is put down as what should have happened. But this is wrong. It promotes counterfactual thinking. It invites people to describe after the event what their opinion is about what should have happened. That's counterfactual thinking, and includes things that in the present could not have happened because they're dependent on events that did not occur in the past. When we ask the correct question in the after action review, what would you normally expect to have happen? We are better able to understand the professional and personal expectations that existed at the time. I expect to be able to access the electronic patient record. I normally expect the anaesthetist to lead on this. So we understand those different expectations and those similar ones. A second question invites people to describe what they actually experienced. And there's no judgment of what is described because it's a bit like building a jigsaw puzzle. You need to lay all of the pieces out on the table to get the full picture. And when everyone has a space to describe that, we get clear about the full picture, what actually happened for you. So those first 2 questions allow us to build that picture because they're described. We're not having an opinion here. We're not making an assessment, we're describing. So everyone is learning right away from those first 2 questions. The third question invites exploration of what got in the way of those expectations being met. We'll also seek to understand what helped the expectations be met or exceeded. We need to look at positive deviance as well. The desire is to understand why it happened and to look at that together, but we tend to ask what questions here to help uncover all the factors that contributed. And then we had the learning question. This prompts participants to identify and articulate their reflections and use these as the basis for action planning for the future. So we're doing it together. So everyone arrives at the starting place for change together. So I'm going to tell you a story of a real after-action review that I led well before PSERF had been even dreamt of, but about 3 years into us using after-action review at UCLH. And the request was made for an after-action review by the ward manager after a patient was prescribed and dispensed a penicillin-based antibiotic, despite being known to have a penicillin allergy, and was wearing a red alert wristband. So beforehand, I had a brief conversation with the ward manager to find out the context of this after-action review, and an hour was allocated in a room near the ward a week after the incident had happened. So at the outset, when we had Jim, we had Sheila, we had the ward consultant, and we had the sister on the ward. So I explained the ground rules for the after-action review and stressed that what was discussed was confidential and that my role was to help them reflect and learn about the recent experience and to determine what individual, team, and organizational learning could be achieved. So the expectations were first explored, and we heard what the doctors and nurses normally expected to do to prescribe and dispense safely. I mean, these include checking the patient's record, the medication history, the medical history, allergies, adverse reactions, as well as accurate record keeping. Then we listened to the junior doctor, Jim, explain that what had actually happened for him was that the consultant microbiologist had called at 2 p.m. on Sunday afternoon to say that Mr. Jones's count has come down and he can come off his IV antibiotics now and go on to oral antibiotics, something like coamaxiclov. So Jim got out his notebook and wrote, take Mr. Jones off IV, put him on coamaxiclov. And about 7 p.m., Jim sat down to do all the jobs from his notebook whilst eating a Mars bar. He'd not gone to the hospital canteen before it closed at 2 p.m, so this Mars bar was his lunch. He picked up Mr. Jones's drug chart and drew a line through the IV and wrote him up for oral coamaxiclov, which, if you don't know, is a penicillin-based antibiotic. And he did not notice the red alert sticker at the top of the drug chart. Sheila, the night nurse, told us what actually happened for her. She was rushing to finish the nighttime drugs at 7 a.m. in the morning, as the day staff get grumpy if they aren't finished, she said. She'd had several admissions that night, and Mr. Wilson in the bed opposite Mr. Jones was causing her concern as he was a falls risk and he kept getting out of bed. When she saw Mr. Jones had an allergy alert band on, she asked if he was allergic to coamaxiclov, and he said he didn't think so. So she took down his IV and dispensed his oral medications. A short time later, Mr. Jones called for assistance because he had a rash developing. Fortunately, appropriate interventions were made, and he remained on the ward for a further 6 hours observation before discharge with a different antibiotic. So then we moved on to why this happened, and I asked the participants what they thought contributed to the problems. Jim was quick to acknowledge his own error in not questioning what he had been told on the phone. He said, "I accepted what the consultant told me to do, rather than making my own prescribing choices." The consultant didn't have the patient's notes in front of him, so didn't know he was allergic to Coamaxiclov. Sheila spoke of how she'd been distracted by rushing and by Mr. Wilson, and this contributed to her not following the policy, and which is to ask the patient if they're allergic to penicillin rather than using a brand name. And she wasn't checking the prescription properly. The ward manager said she wondered if the drug round by night staff should be reviewed. The increase in nighttime admissions over recent weeks were making it tough to complete the drug round. So she took this way as a team action to work on. The ward consultant recognised that Jim not being able to get a hot meal on a Sunday in the hospital was a recurring problem and an unacceptable one. And she took her concerns forward via the consultants' meeting with the exec board. Other actions arising included looking at getting tabards for drug dispensers to signal the need to focus on this, on their drug round. And Jim said he's going to always bring his own lunch in at weekends. And in the NHS now, we're using an analysis tool to look at those contributory factors, and it's called SEEPs. You don't need to worry about it too much yet, but I just wanted to sort of illustrate how some of those contributory factors that led to that incident would be looked at. And then you can start to look at where the mitigations can. And obviously in the top right-hand corner, the tools and technology. Nowadays, because we have electronic prescribing, there would be an automatic block on a patient like Mr. Jones getting Coamaxiclov. You could not actually do it. So we're building safety into our systems, but there'd be other ways of looking at that. So there's an example of a real after-action review. So why does it add so much value? What is it that's happening? Well, you see your clients and your carers under pressure every day at the best and worst moments in their lives. So you understand what pressure can do to people and their animals. But unexpected events, patient safety problems, disruption to normal business activities do the very same. They put your people, your processes, and your systems under pressure. This is why taking a short amount of time to look at how the people, processes, and systems responded under pressure is where the real gold lies. There is so much treasure waiting to be explored when we reflect after the pressure has eased. Every incident is like a door opening on that treasure, and an after-action review is a chance to get to the gold before the door of normality closes again. The word tacit comes from the Latin tacitus, meaning silent or unspoken. And after-action review is a highly effective process for gathering tacit knowledge. Explicit knowledge is what's found in textbooks, the research papers, the policies in an organization. It's what you're told when you start a new job. But tacit knowledge is what you learn after months and years in a job. It's about how things get done, who's reliable, who's not, the quick way of getting things done. And after-action reviews capture this knowledge so that you can put it to good use and share it amongst yourselves. So after action review is like a sort of speed dial on conveying knowledge, tacit knowledge to an organization. It dramatically speeds it up. The psychologist Sidney Dekker writes about work as imagined and work as done. The example here is that the town planner imagined that everyone would walk on the curved paved area. Excuse me. But in reality, people want to go in a straight line between buildings. So in a pre-anaesthetic check, for example, work is imagined. Might be that the full checklist is completed every time. An accurate weight is recorded. The blood work is reviewed before anaesthesia. But work is done. The weight may be estimated if the animal is stressed or uncooperative. The bloods may be skipped for young or low-risk patients. The checklist might be done mentally rather than written. The reality is that teams constantly balance efficiency and safety. And an after-action review is a place where work as imagined is made more explicit, and the reality of daily life becomes more clear. Irving Goffman, the highly acclaimed American sociologist, said, "There is no interaction in which the participants do not take an appreciable chance of being slightly embarrassed or a slight chance of being deeply humiliated. Life may not be much of a gamble, but interaction is." We know that speaking in groups, especially hierarchical ones, like in human and animal healthcare, carries risk. We don't want to be judged or criticised if we didn't do something correctly. But we can't learn from secrets. We can only learn from the full picture. So the after-action review is designed to be a safe and open conversation. And that is what much of the training that I lead focuses on, how to create a safe environment for these conversations. After-action review also adds value because they support staff. We know that isolation and the rumination after events that happens increases staff stress, who may blame themselves when they're on their own with their thoughts, or be uncertain how to make some sense of something that has happened. In the after-action review, participants get to understand the full picture and hear from others about their experiences. So get clear on the full picture, and they can contribute to solutions for the future. So they're not passive, they're active. They also get listened to, which we know has a protective factor for staff stress. So in summary, why we need after-action review is every unexpected event opens a door on your processes and how people interact with them. Tacit knowledge is highly valuable, but rarely accessed. And work as imagined is not the full picture. Hierarchy gets in the way of open and honest conversations, and psychological safety needs to be actively created. And being heard and seeing the bigger picture builds resilience and reduces stress in staff. So I'm going to ask Jess to come in here. I'm going to stop sharing because Jess has started using after action review at the Ralph, and she's going to tell us a bit about that.
Yes, so we've only been using after action review for a short time, so this is our initial experiences, but they've already changed the way we reflect on these complex patient safety events. And a bit about how we do them here at the Ralph. We've previously called them case discussions. We previously held them on situations where the outcome has not been what we intended or expected to happen for the patient. We want to try and flip that a bit more and do some on future scenarios where things have gone better than we expect for the patient as well, because it can be equally as good for learning in that as it's a scenario too. We have tended to do them a bit too long after the event in the past, so we're going to try and make sure they're a bit quicker and sooner after the event so we can get that fresh recollection of people's memories. We tend to use them we've got a meeting room here at the hospital, so we will use the meeting room and we will invite the people who are directly involved with that patient, but also it's open invitation. We're a teaching hospital, we have interns and students, so we like to open up to include everyone who can potentially learn from the discussion. And now that I've been to Judy's excellent in-person training, which for a full day event with her, and I've become a trained AAR conductor myself, I tend to facilitate the discussions, but I'm hoping we can have more people at the Ralph who are able to do this as well in the future. So we've done a few of them, but out of respect for our patients and their families, and to maintain confidentiality, I won't be discussing sort of the real cases today, but I'll use a composite scenario that reflects the type of patient safety events that we have reviewed and demonstrates how we applied that AAR methodology in practice. So the composite case I'm going to describe is a dog that's admitted for a routine cruciate ligament surgery, a TPLO procedure. The surgery and anaesthetic were uncomplicated, and the patient was transferred post-operatively to the ward for routine post-op care. Over the next 24 hours, the patient is quieter than expected, reluctant to eat, slow to mobilise, and generally not following the anticipated recovery trajectory. And different members of the multidisciplinary team interpret these signs differently, be that due to pain, due to stress, due to residual anaesthesia drugs in the system, or simply a slow recovery. But the patient's condition subsequently deteriorates, requiring further investigation and treatment. So in cases we've looked at before, there's not always a single obvious error or adverse event that's happened. Instead, there could be a series of small observations or decisions or interactions that have accumulated over time through a patient's journey in the hospital with us. So in the reviews, in the after action review sessions, we apply those 4 questions that Judy described earlier. So starting with what we'd normally expect to happen, which is not a question we used to use before I went on this training and learned more about this approach. And it was really, I've seen it be quite a game changer in how those conversations happen by starting with describing what are normal expectations for what would happen. So in this case, with our dog having a TPLO, we would expect an uneventful recovery from anaesthesia. We would expect progressive improvement in comfort and mobility and appetite. We would expect that the routine nursing and veterinary assessments that are being done confirm the recovery is on track with what we expect to happen. And we'd expect prompt escalation if recovery deviates from that expected trajectory for that patient. We'd also expect clear communication and shared situational awareness across the team as to how the patient's doing and what's happening with them. And then moving to what actually happened and getting those perspectives from the people in the room who were directly involved with the patient, from their perspective as to what actually happened. So reported that the surgery itself was uncomplicated, that recovery was slower than we expected to happen, that different team members recognised concerns but interpreted them differently, and that a lot of small deviations from the patient's recovery or expected recovery accumulated before the patient's deterioration really became fully apparent. So there's no single trigger event, but several contributing factors as to how this was progressing. And then moving on to why there was a difference between our expectation and what actually happened in reality. And again, rather than focusing on blame and individuals and asking who made a mistake or who missed something, we have a more wider discussion to explore these factors. So thinking about how different people interpreted the same clinical picture differently, reflecting on the communication or lack thereof potentially of between the different members of different services and the multidisciplinary team that we have here at the Ralph. That communication can break down very often. It's often a key finding in reviews that communication or breakdown in communication is a contributing factor in looking to improve that in various ways. We also can explore how escalation of patient symptoms may be lacking, and decision making based on that lack of escalation, lack of information may have been lacking as well. Also exploring the human factors in a case like this, busy ward nurses with lots of patients to care for and potentially sicker patients in their mind that they were looking after at the same time, having been behind on treatments, needing to have multiple drugs administered to patients and treatments going on, not having had breaks potentially as well. Those sorts of things can contribute to people's individual performance and how things felt for them on that day or during those days. And then looking at the wider systems and processes that we have. So what are our means for communicating? Have we got a protocol for how a ward nurse would escalate to a vet if they have concern about a patient? Is there different ways that we do that, and can we streamline that and make that more effective? And are there any environmental or organisational influences that could affect a situation like this? So was a patient in a kennel in the ward that's sort of a bit more tucked around the corner and not so visible to the ward staff, for example? We look at an environmental factor as to potentially missing some clinical signs and symptoms. And then moving on to what we've learned, or what we can learn to improve performance in the future, and to improve how we can handle these situations. So we can learn to improve how we recognise unexpected recovery trajectories. So being clear up front about what we expect to happen for patients who, having a fairly routine and common procedure, would expect a certain timeline of things to be happening. And if we're going outside of those boundaries, then that should hopefully provide some clear escalation triggers to then be able to say, actually, we expect them to be walking by now and they're not. So what should we have them reviewed? Having better MDT, multidisciplinary communication and handovers. So when we're having the patient come back from anaesthesia in recovery to the ward, how are we handing over that information? And then as we have patients with us for 2 or 3 days, you can have several different ward nurses and several different vets or interns from that service looking after and being responsible for that patient. So how we're actually handing over effectively how that patient's doing between the different staff members, and maybe putting together some more guidance protocols around that to have a strengthened handover process. And then increasing the shared situational awareness. How can we make sure we're doing good documentation and record keeping to ensure that patient situation and status is being accurately and frequently documented, so that anyone reviewing that patient's sort of trajectory can see the trends that are happening. And also supporting staff to speak up when they are concerned, so that the ward nurses, if they are feeling that they're worried about a patient, feel supported and able to escalate and raise that. And even if they maybe potentially initially don't get the response they expect from that escalation, having other channels and means in place so that we can empower staff to escalate and raise concerns when they feel that they have a worry about a patient. So I think what's really valuable for me in starting to use this approach and having a more structured framework around our case discussions in this way is to shift that discussion from what went wrong to what we normally would expect and what the variance from that was, because we can then make sure that we put in place things to structure what we expect better in the future and spot that deviance from it at an earlier point in the process. And it makes the conversation a lot less defensive and much more curious. We try and apply a real lens of curiosity to how we look into these things at the Ralph, because if we aren't curious, we're not learning. So having a framework that makes us be more curious really does support that approach. And then rather than looking for a single root cause, a single point in time where things were taking a turn potentially, we compare the expected patient journey with the actual patient journey over several days potentially, and to see what was expected at different parts of that journey and then what actually happened. And then encouraging contribution from everyone in the room, as Judy said, trying to create a non-hierarchical situation and setting where nurses, vets, patient care assistants, any allied professionals, non-clinical staff all have different perspectives on what they expected to happen, and those perspectives are equally valuable. So you want to hear from everyone in the room to draw out their views. And as a facilitator of these sessions, I've found that AAR really does help create a psychologically safe environment to have these conversations in, and produced a richer discussion, I think, and more meaningful improvement actions than simply asking, okay, what happened? So really good reflections, and it's been a good experience so far here at the Ralph, and we are definitely going to continue using this approach in future and doing more of them, and for more, not just when things don't go as expected in a negative way, but also in a positive way when we get a better outcome for patients too.
Wonderful to hear about this, Jess. And can I ask you just a couple of questions?
Yeah.
Obviously, you can't, as you say, we've got to respect patient confidentiality, but how are staff responding to this? What are they saying about participating in after action reviews?
It's really interesting that the more we do them, the more it normalizes doing them, and the more people therefore want to do them. So I've had, even yesterday, a vet approached me to request that we have a discussion about something that happened with their patients, which to me is an indication that we are starting to really normalize this happening. And it's also reassuring when you hear people's voices in the room, that people who are in more junior roles and who maybe wouldn't normally be expected to speak up, and certainly in other settings I've worked in too, that normally it's left to your senior or your boss to lead on things and speak on things. Actually encouraging junior roles to speak up and seeing that happen in practice is really, really valuable.
Incredibly valuable. We know the science on this, don't we, Jess? That actually people feeling safe enough to speak out in an after action review directly correlates to being comfortable to speak up in other circumstances, so that everyone is switched on and able to work safely together. Another question,
Mm.
if you weren't doing after action reviews like 2 years ago, 3 years ago, what do you think would happen in situations like this?
Either conversations wouldn't happen at all, which, but I mean, we have had conversations and case discussions for several years at the Ralph, but I think it's more about the way we approach them. So I think we wouldn't benefit from as rich and deeper learning as we have done from the last few sessions where we've used this more structured framework and tighter approach to it. And really by asking that what was expected question, really, I really felt it depersonalized the context of the situation, because it wasn't about an action that somebody did or didn't do. It was about this is what we would normally expect to happen in this scenario for this type of patient, this age, this breed, this gender, etc. For this situation, we would normally expect this to happen. So when we looking at deviation from that and what actually happened, it really helps to depersonalize and to focus more on those system issues
Mhm.
than individual actions as well.
No, it's great to hear, and listening to your using the word "we" a lot, and that is it makes my heart sing, because what's happening is everyone in that after action review is learning together, so they're all gaining enormously from it. Whereas that the conversations that might have taken place to solve problems before might not have involved everyone. And back in the NHS days, the investigator of something learned a hell of a lot and wrote, a big weighty tome like that, which contained all the learning, but no one else knew about it.
Hmm.
So,
I think it's really beneficial as to why we have we open it up as an open invitation to all staff to attend, and we usually get a good room full of people, including vet interns, vet students, student nurses, people who were not directly involved in the patient's case, because we need to spread that and share that learning so much more widely as we can.
yeah, well, that's tacit knowledge in action, isn't it? It's being transferred easily and inclusively. Lovely to hear. Thank you very much for sharing that account and that case study and what Jess has been saying. What we're hearing about here is an organization that is constantly seeking to excel. Rather than walking past problems, the Ralph, they walk towards them so that they can ensure that learning is identified and put to good use for all their future patients and carers and their staff. This is what high performing organizations do. They could seek to continuously improve. And Jess and I have put together a list of topics that you might find helpful in general practice to do an after action review on, perhaps a patient who died unexpectedly during a routine procedure, or there was a delayed diagnosis that led to deterioration, or a patient is discharged and readmitted as an emergency within 24 hours, or a nurse notices that a wrong patient's being prepared for surgery, or a client points out that the discharge medication doesn't match the instructions, or a collapsed patient arrives and the team performs a highly effective emergency response. The positive one, F, is key. And Jess has highlighted how, that is the maturing response. Once you've got the hang of after action review, you realize the gold is in the open door after a successful retrieval of a patient, for example. So there's a few examples of clinical context, but what about operational wise? What happened? Maybe you could do an after action review after a team successfully manages multiple simultaneous emergencies, a team under pressure. What enabled you to perform? And where were the sticky bits in the processes? What about managing on a day when half the team called in sick? Or coping with a major IT outage? Or managing a challenging client situation? Did it have a good outcome? What enabled you to have a good outcome and retrieve the trust and relationship with the carer? Or what about you had a really busy bank holiday weekend? The system was under pressure. Learn from it. Maybe the first week of a new graduate joining the team. Always used to lead after action reviews after the new doctor induction phase with the junior doctors to identify what they'd learned, what they'd found valuable and useful in their induction, and what hadn't been so useful, so that we can continuously review and improve our induction program. Or after relocating, any untoward event or routine event can be an after action review can be used for that. But you don't need to take my word for it that after action review can be so valuable, or mine and Jess's. The research evidence is strong too, and it's growing. After action reviews are one of the highest impact, low cost learning interventions studied in organizational psychology. There was one research paper that showed that, for example, that after patient falls, after action reviews led to a 46% reduction in a large acute hospital over 5 years. That is massive, because those directly involved, the healthcare assistants, the nurses on the ward, sometimes the patients and their carers, were learning in a very responsive and reactive way from what just happened. And it enabled all the staff to remember what they knew already and to become much more alert to the causes of falls and how to prevent them and how to respond effectively when they happen. And there's a major meta-analysis of 46 published and unpublished papers, which shows that that debriefs using after action review, the 4-question model that Jess talked about, it improves your team performance and outcomes over control groups by approximately 25%. That is a hell of a lot. And of course, across many studies, what we're also seeing are this cognitive and learning outcomes are systematically improving, your team process variables are improving, and decision-making performance is improving, especially in ambiguous environments and situations without clear feedback loops. So the research is there, and perhaps someone listening to this webinar could pioneer some research in using after action review in veterinary practice. It could be very, very valuable for all concerned. Jess mentioned training. That 4-question model is deceptive. It looks simple, but what happens in an after action review is rarely simple. People are usually speaking about what matters to them a lot, what happened on a difficult day at work. So the facilitators of these meetings need training to create that psychological safety and ensure every AAR is a success. So we've still got some places on the open access courses I'm running in London and Manchester in October. So please do get in touch if you're interested. And I know that the Ralph is keen to organise a CPD day for veterinary staff. So there's some options to help you. Now, we're going to come on to our question section soon, but in anticipation of that, I'm just going to share with you some answers to some of the common questions that we get asked. How long do you need for an after-action review? So I've drawn a little box here to suggest that, it depends on the complexity of the event. If it was a really complex event, you might need 2 hours, particularly if you've got quite a lot of people contributing. But if it was a simple event, and you've only got a small number of people contributing, it will be shorter. And if you think about it, you've got maybe 7 people in an after action review. Each one of them is answering the first question. That takes 14 minutes. That takes 7 minutes, and then each answering the second question. That's another 7 minutes. You can, if you chunk it up, you can see that you probably need an hour. But when people get very comfortable with after action review, where it becomes normalized in an environment, you know, and it's not a very complex event, people will settle quickly into the process, and they can be much shorter. The sort of other common questions that we have is who can lead after action reviews? Well, you could go and lead one tomorrow on something very, you could do one for yourself tomorrow. Well, I actually always do them on Fridays. I look back at my week and I say, what was I expecting to achieve this week? And what has actually happened this week? And then what has got in the way of me meeting my expectations? And what has enabled me to meet my expectations? And then what have I learned? And what am I going to do with that learning? So you can do your own after action reviews. You might use it to structure a conversation with a member of your team who perhaps isn't doing, pulling their weight. You could, talk about what you expect, what you'd normally expect of someone at their grade and in their role, and then talk about what you're actually noticing, and then invite them to talk to you about what might be getting in the way for them to meet those expectations. So I'd take it out for a walk, take the 4 questions out. And even if you ask just one of them, what have we learned today? You're doing part of an after action review. You've got that curious mindset that Jess spoke about. But ultimately, if it's going to be, a patient safety event, some training would really ensure that it's successful and psychologically safe. The other question that often arises is how soon should you hold them after the event? And again, that very much depends on, how emotionally charged the event was, because people need time to process and settle afterwards, but they don't need so much time that they get into that rumination and stressful state. So signaling that an after action review will be held at such and such time is in effect quite a helpful and healthy thing to do, so that people know we're going to regroup, we're going to look at this together, and we are going to work out what we can do to mitigate this in future, can reduce stress. But in teams that are very comfortable with after action review, they can be done within days. At the moment in the NHS, we're struggling because getting staff back together again gets in the way. But in a smaller practice, that's not necessarily such a difficulty. Finally, before we stop and share some, and we come to you for your questions, I've just thought I'd share a couple of reflections that in my conversations with Jess and Tony, I've learned a lot about veterinary practice, and I thought I'd share some of the differences that I've noticed. In veterinary practice, you have quite a low amount of political and professional oversight in comparison to the very high degree of political and professional oversight we have in healthcare, in human healthcare. And it seems to me that you have a relatively limited research base for policies and protocols to guide all behaviours and processes. Whereas in human healthcare, we have extensive and conflicting research base to guide policies, behaviours and processes, largely because we've had such an extensive history of investigation. Every investigation seems to come up with a new policy that has to be followed. And that's not possible. Someone recently told me that it would take 2,000 hours to read all of the policies in their own discipline. In veterinary practice, what I understand is that you've had a short history of incident review and local learning activity. Whereas we've had a very long history in human healthcare of searching for a single root cause and individual culpability. And in veterinary practice, you have a competitive marketplace to attract your clients and your patients. Whereas in the NHS, anyway, we have a very uncompetitive marketplace to attract clients and patients, which all means that I think that veterinary practice is an ideal place to introduce after action review. In human healthcare, the 25-year history of serious incident investigations has meant the switch to the use of after action review has been so difficult because there's such an expectation of lengthy reports and root cause, a single root cause identified, and that every investigation will be incredibly in depth, which means we've missed most of the small stuff before it got big. The gains that you'll get from using after action review will give you a competitive advantage because group learning promotes adaptation, innovation, and responsiveness, better clinical outcomes for your patients, lower staff stress, and efficiency gains in operations. So I very much hope you'll use it in your workplaces.